So we spent a bit of time talking about the smaller lesions, difficult positions. We've shown non-granular, we've shown granular, we've shown some in the difficult positions, although we'll have to do another session to show all the myriad of other ones throughout the colon that were larger that we had in the second presentation. But this is a presentation of 6 or 7, I think 6, very, very dangerous polyps. So if you remember, so I did it at the end on purpose because I wanted you to take this away from the session. So if you see something like this, really blink, and blink a few times, not just one time. Christoph.
An ulceration, you see immediately at the top.
Yeah, so I would like to continue this conversation by ignoring all the ulcerations. The ulcerations are from previous polypectomies, performed somewhat in haste, maybe by the person referring, but of course, maybe you didn't see this other lesion at the same time. It's really quite difficult and quite subtle. So of course, these things happen, like you can't go back and be critical. So there are some polypectomies that happened here a couple of weeks before. So the ulcerations are not part of the lesion we're discussing. Okay, so here's the polypectomy sites. And then when we get to the lesion itself, we're going to make a little pause so you can see it properly. So here maybe.
Yeah.
So blink reflex of that?
Bad.
Bad. John, blink reflex, are you there, John? Can't see.
Yeah, I'm there. I agree, bad. And if for the people tuning in, it's very easy to see this is not the same as before. And if you look at the top left, between about 9 and 11 o'clock, you have what was be normal adenomatous tissue. And then you run into kind of an amorphous bit of polyp, and then it changes again, and you'll see it goes from being pale to very dark red in the center. And this looks good to me.
So these combinations that you should hear these combinations together: 2A plus C, non-granular, right colon, quite large. These things should be ringing alarm bells in your head if you're pre-assessment risk. And Lynn, can you just tell me what the pre-assessment, what the risk score says for this lesion?
Yeah, I'll show you.
You don't have to show the slide, maybe you can just, okay.
There it
Too
is.
late. Okay, so the SMIC score is 21.9%, right? So the pre-assessed risk for this lesion is an order of magnitude higher than the one before.
Yeah, so so what you're looking at is you've got cancer, and what you're trying to determine using your GIEQs classification, is this superficial cancer, which is potentially endoscopically resectable, or is this deep invasive cancer? And as you're alluding to, it comes down to what you're actually looking at is the vascular pattern, the regularity of the vascular pattern, but also the diameter of the vessels and whether they're distended or attenuated. And irregular, and that'll tell you the difference between. So if you've got a regular pattern in the demarcated area, it usually indicates it's superficial rather than deep. And if it's irregular, that means it is irregular. It means you've got deep invasion, and therefore that's not endoscopically resectable.